In this presentation, I'd like to share with you some of the thought process that we went through to identify the optimal way that we feel we should address these flexor lacerations. This is my disclosure. The take-home message is basically the suture needs to hold the tendons together long enough for them to heal. It needs to be strong enough and reliable enough, and it needs to be simple, available, reproducible, and importantly, biologically friendly. When I finished my hand fellowship back in 88 or 89, I returned to the Royal Adelaide Hospital. We had pretty bad outcomes for and follow-up, and about a 20% rupture rate, which was clearly unacceptable. We're using the Kessler type repair with Kleiner traction and the flex wrist with poor follow-up arrangements. It was interesting at the time that Professor Strickland, stratified the important criteria for a flexor tenorrhaphy, and in fact he had sufficient strength at the bottom. With easy placement as an important criteria, and we felt that maybe we should change this and the biomechanic to have a repair, it must be biomechanically sound to start off with, so that actually does the job to hold the tendon together. It should be biologically inert and so not interfere with the healing process, and it needs to be user-friendly so that most surgeons can do that, and we need to evolve towards this priority rather than the opposite. And it's interesting that I actually presented these three criteria at the first APFSSH meeting in Perth in 1997, and as I was pulling the talk out again, I see that the same talk is actually, principles haven't changed. In fact, nothing much has changed over these years, maybe. So when we're looking at suture technique, there's grasp and performance under load and serum materials. There's a lot of things to consider. And so we looked initially at the Kessler repair, which was a simple repair but fairly poor biomechanics. The Savage repair, which was actually available at the time, which seemed to be the benchmark for the most, the strongest repair, had good biomechanics but was technically quite difficult. And it's important, as we've heard, that the holds on the tendon must be grasping and not looping. And it's interesting that the modified Kessler, it looks good when it's put in, but under load, it actually straightens out and becomes a simple loop without any locking characteristics at all. But the single cross grasp, which eventually became the Adelaide repair, actually gets tighter as the load comes on, as distinct from the modified Kessler. So we thought the Savage repair was a little too complex, and we decided to perhaps look at the single cross rather than a double cross. And in fact, we compared this double cross that Savage rather designed, and the single cross, and we found that they had equal strength under biomechanical loading and porcine tendon testing. So we could simplify the repair right from the start by simply removing one of the crosses. Our initial series in 1989, and so we've been doing full active mobilisation since 1989. 32 tendons using a 6-strand single cross repair with full follow-up. We had no ruptures and very satisfactory outcomes. So if we're looking at the criteria for our core sutures, it needs to be biomechanically sound, strong enough with low gapping potential. But it's important that all the strands must be loaded concurrently. And so if you have strands that are locking or don't slide, then you may have eccentric loading of the strands. We know that most of the ruptures occur at the knot when it's excessively loaded. Well, we also found that 4 strands of 3/0 braided polyester was actually as strong or stronger than 6 strands of 4/0. So it meant we could perhaps reduce down to 4 strands and not lose any actual strength of our repair. We found that the tensile strength of a 4-strand Adelaide type repair was around nearly 70 newtons with minimal gapping and seemed to be biomechanically very adequate for our repair. It has very low gapping potential, and I'll mention that in a minute if we have time, but the Kessler has a very high gapping potential with this transverse suture pass and redundant suture and deformable suture grasps. If I just expand on that, if you look at this, there can be repair gapping which allows elongation, or repair gapping that it does not elongate. So this is the Kessler above, and as the load comes on, this transverse strands are incorporated in the gap, and it gaps, and you get this elongation because of with the gapping. In the locking, where there's a locking grasp, such as the Adelaide repair, we can see here that as the load comes on, the grasps stay in place, but there can be some concertinaing along the core strands, and so this is actually gapping, but it's not actually elongating, and so all the epitendinous needs to do is just prevent this concertinaing. It's important with the epitendinous not to use a cutting needle, as this may damage the core stitch, so always use Prolene. And it's interesting, if we look at the types of repairs, which has given us good insight into where we can go, where we can improve our outcomes. And so the type 1 we've called knot unravelling. So basically you need to have a good knot, but some of the composites actually tend to slip. So braided polyester may be better. If it ruptures at the knot, it means you've overloaded it. If you damage the strand by the epitendon suture, then it'll rupture away from the knot. And if it just simply pulls out, then the grafts have not been sufficient to hold it in place, or the biology is poor enough, which has meant that the repair has really worked its way out over perhaps even months without it healing. We know that the repair must be biologically inert to not interfere with healing, with minimal surface sutures and ideally a single knot. And if you look at the vascularity of the tendon itself with this vincula, we note that the Kessler basically comes straight across the tendon and may in fact strangulate the portion closer to the repair. The Savage is better with these three grafts, but in fact the Adelaide repair with 2 grafts, 2 on either side, seems to have the less grafts, less vascular interference and more biologically inert. And ultimately, the repair must be user-friendly, and so reduced number of 4 strands, simple shape, and needs practice. And there's a whole range of sutures to use. They need to be strong and reliable, inert and stiff, and with a secure knot. And so we created this matrix of the type of repair options at the top, and the capabilities or the requirements of each of these strands. And we found that the braided polyester has really the best characteristics of availability, slide, ease of use, knot security, elongation, and strength. With the composites are close behind, but they tend not to hold the knot as well. So really the Royal Adelaide Hospital, as I mentioned, from 1989, we've been fully active mobilisation, using initially the 6-strand modified Savage, and then since 1994, the technique has been a 4-strand single cross grasp, so-called Adelaide repair. This provides a very strong, reliable repair with typically 430 braided polyester, and with immediate active mobilisation and an extension block splint with the wrist extended slightly, and much better tracking and follow-up to make sure our results truly reflect what we hope we're doing. So here's one case where it's been repaired, full active mobilisation and a wrist extension splint. So basically for the Adelaide sonography, a review in 1989 showed a 20% rupture rate. By introducing this stronger repair, which was easier and more effective, we reduced it to 5% rupture rate within 2 years. So biomechanically sound, biologically inert, user-friendly, has provided a predictable outcome, a low rupture rate, good functional recovery, and remains our technique of choice for both flexor tendons and also other tendons within the hand and even lower limb. Thank you.